The heart is an amazing organ. It beats about 100,000 times a day, more than 2.5 billion times during a 75-year lifespan. The primitive cardiac tube is a midline structure from which cephalically the truncus arteriosus is located. Centrally is the origin of the ventricles, and caudally the origin of the atria. Normally the primitive cardiac tube has a dextro loop, which means that the center portion bends to the right. From the right bend, we have the origin of the right ventricle, and from the left bend, the left ventricle takes off. Cephalically, the truncus arteriosus is the origin of the pulmonary trunk and of the ascending aorta, and caudally the atria. While the primitive cardiac tube is bending to the right, there is septation and rotation of the truncus arteriosus, and the final result is the pulmonary trunk in front and to the left of the ascending aorta. And the aorta then reflects the position of the right ventricle, while the pulmonary trunk reflects the position of the anatomically left ventricle. When the primitive cardiac tube bends to the left, then the right ventricle is to the left of the right ventricle. And this is a situation where we call inversion of the ventricle. The truncus arteriosus is a midline structure that septates. The ventral part is going to give origin to the ascending aorta, and the dorsal part to the pulmonary trunk. The final location of these vessels is a rotation to the left, as is indicated, where the pulmonary trunk ends ventral and to the left of the aorta. And this is the normal situation that occurs whenever there is a dextro loop. Any mal-relationship between the ascending aorta and the pulmonary trunk is called transposition of the great arteries. The situs inversus, or mirror image of the normal relationship, places the aorta behind and to the left of the pulmonary trunk. A detransposition occurs when the ascending aorta is ventral to the pulmonary trunk. Levotransposition indicates the aorta to the left of the pulmonary trunk. And again, it can be dorsal to the side or ventral to the pulmonary trunk, and indicates the presence of a levo loop. When we refer to right and left, this means the inner architecture of the chamber. In other words, the right ventricle anatomically is a trabeculated ventricle, and the left ventricle has a smooth inner lining. It's a U-shaped cavity, and it is seen either to the left or to the right of the right ventricle. Position dextro and levo means the position of the heart. When it is in the right hemithorax, that's called dextrocardia. When it is in the left side, is levocardia. However, dextro and levocardias can have a normal or an abnormal relationship of the atria as well as of the ventricles. When we talk about venous and arterial chambers, venous is the one that receives unoxygenated blood, and arterial is the chamber that receives oxygenated blood. Heart imaging techniques include the chest radiography, cardiac fluoroscopy, echocardiography, scintigraphy, magnetic resonance imaging and spectroscopy, computer tomography, and angiocardiography. A traditional cardiac series consists of frontal and lateral views of the chest, supplemented by RAO, right anterior oblique, and LAO, left anterior oblique views of the chest. The latter are traditionally used when we perform angiocardiography. The availability of echocardiography has made that the oblique views are not used in most centers throughout the world. The first of a cardiac series is a frontal view of the chest. Note that the patient is placed against the cassette. The chin is above the cassette. The elbows are bent forward in order to have the scapula lateral to the lungs. The patient must be straight, and the film is taken in deep inspiration. The ideal frontal view of the chest should be taken with a three-phase generator, and the kV should be about 120. When dealing with a single-phase generator, the kV should be about 140. In the frontal view of the chest, we should be able to see behind the heart the pleuroesophageal line. We should see the pulmonary markings overlapping the ribs, and the ribs should be distinctly visualized. The patient should have a deep inspiration to best assess the lung basis. Cast corrosion preparations were utilized to show the anatomy of the cardiac chambers. Note in the frontal projection of the heart the anatomical position of the right ventricle, which is not a border-forming structure. To the right of the right ventricle, we see the right atrium. We note to the left of the right ventricle, the left ventricle. The pulmonary trunk continues with the cephalic portion of the right ventricle. In red, the branches of the right coronary arteries, and in blue, the branches of the left coronary arteries. The diagram of the right side of the heart shows the superior vena cava medial to the ascending aorta. This occurs in adults, particularly when there is dilation and elongation of the thoracic aorta. In infants and children, the right vascular segment of the mediastinal silhouette is formed by the right wall of the superior vena cava. The superior vena cava ends in the right atrium, which forms a convex curve close to the diaphragm. And in the junction of the right atrium with the diaphragm, we note the termination of the inferior vena cava. In some skinny patients, at deep inspiration, we may see a straight line that is formed by the right wall of the terminal portion of the inferior vena cava. This is a coronal MR examination that was obtained at the entrance of the superior vena cava in the right atrium. Note that the two vascular structures that form the right cardiomediastinal border are the superior vena cava above, which shows a flat or straight edge, and the convex right wall of the right atrium. Note to the left of the superior vena cava, the arch of the aorta, and the pulmonary artery below it. In this diagram of the right ventricle, note that it is not a border-forming structure, that it is continued by an over-shortened pulmonary trunk, and the reason it appears short is because this vessel is directed from front to back. To see the entire length of the pulmonary trunk, we need a lateral view of the heart. The right pulmonary artery branches at a lower level than the left. This is the dextroangiocardiograph, which shows opacification of the superior vena cava. The arrow on the left image indicates a slight reflux into the terminal portion of the azygos vein. The superior vena cava, which is number 1, terminates in the right atrium, which is number 2. And note some reflux into the inferior vena cava and hepatic branches, which is number 3. The angiocardiogram to your right shows a passage of the contrast to the right ventricle, which appears here in systole, and it is indicated as number 4. The right ventricle continues with the pulmonary trunk, number 5. The curved superior arrow indicates a radiolucent space, which normally is occupied by the left atrium. There is like a radiolucent ring formed by the superior vena cava, right atrium, outflow tract of the right ventricle, pulmonary trunk, and inferior margin of the right pulmonary artery. When this radiolucent area opacifies during the dextro phase of the angiocardiogram, it indicates a right to left shunt at the atrial level. Note the lower arrow indicating reflux of contrast into hepatic veins. This is a sketch of the dextroangiocardiograph, where we can see the right atrium, the right ventricle, the pulmonary trunk, and the branching of the two pulmonary arteries. This is the sketch of the left atrium. Note that it is a disc-like structure which occupies the most dorsal portion of the heart. Note that it can touch the right heart border, particularly when it is enlarged, adding another arch to the right heart border. Note that the left auricular appendage projects Along the middle third of the left heart border, the inferior third of the middle third of the left heart border is the home of the left auricular appendage. It bulges that region when the left atrium is enlarged. Note also that it is surrounded by the bifurcation of the trachea, and that behind it we see the thoracic esophagus. Cephalic enlargement of the left atrium will widen the interbronchial angle and will displace dorsally the thoracic esophagus at the level of the heart. It would also cause a density noted through the heart, the so-called disc sign of left atrial enlargement. This is a diagram of the left ventricle. Note that there is an area called the point of opposite pulsation, which is the junction of the superior portion of the left ventricle with the middle third of the left heart border, the site of the auricular appendage and above it of the pulmonary trunk. This is called the point of opposite pulsation because the inward motion of the left ventricle coincides with an outward displacement of the structures above it. That point should be about the same level as the junction of the superior vena cava with the right atrium, which the French call the point D, which represents the word droit, which means in French right. The point of opposite pulsation on the left heart border is called point G, from the French gauche, which means left. When the point G is above the plane of point D, this generally indicates enlargement of the left ventricle. When it is displaced caudally as it relates to point D, that generally is associated with the right ventricular enlargement. Note that the ascending aorta projects beyond the right wall of the superior vena cava, and this occurs in adults due to elongation and dilation of the thoracic aorta. The aortic knob is the superior arch of the left mediastinal vascular shadow, and it is the site where the transverse and descending aorta meet. It is the junction of the transverse aorta and the descending aorta. This is the coronal MR at the level of the ascending aorta. Note that the left ventricular contour is formed by the free wall of the left ventricle. And note that it continues with the aorta, and that the aortic valve sits in the center of the heart. Note to the left of the ascending aorta a cross-section of the pulmonary trunk, and between the pulmonary trunk and the left pulmonary artery and the aortic knob is the region called aortic pulmonary window. To your left is the dextroangiocardiograph, and the curved arrow indicates the position of the pulmonary valve. And note the bifurcation of the right pulmonary artery indicated as number 6, and the bifurcation of the left pulmonary artery indicated as number 7. To your right is the levoangiocardiograph, which means the opacification of the left heart chambers. The left atrium appears as number 9, the pulmonary veins as number 8. Number 10 is the left ventricle in systole, and number 11 is the opacification of the ascending aorta, which is in this infant does not form the vascular arch of the right heart border. In this patient, the vascular arch of the right heart border was formed by the superior vena cava, not seen in this angio. This is the levoangiocardiograph, where the left ventricle is in systole, the picture to your left, and in diastole, the picture to your right. The left atrium is indicated as number 9, and it is a crab-like structure where the legs of the crab represent the pulmonary veins. The ascending aorta is number 11. The right brachiocephalic artery, the nominate artery, is indicated as number 13, and the descending aorta is indicated as number 12. To your right, note the smooth inner-walled elliptic left ventricle, which is indicated as number 10. The arrow to your right represent the sinus of Valsalva, which are protrusions in the outline of the supravalvular portion of the ascending aorta. And it is at that level that the coronary arteries arise. Number 14 indicates the left carotid artery. This is a diagram of the left heart chambers. Note the left atrium, which occupies the center of the heart and is the most dorsal chamber of the heart that receives blood from the lungs through the pulmonary veins. Note that it continues with the left ventricle, and both structures overlap in the frontal projection. Note the thoracic aorta, and that the right wall of the ascending aorta projects medial to the superior vena cava, because this is a diagram of a child. This is a composite color diagram of all the cardiac chambers. In green is the right atrium, which forms the right heart border. In blue is the right ventricle, which is the most ventral cardiac chamber and not a border-forming structure. In yellow is the outline of the left atrium, which projects to the right when it is enlarged. It also enlarges cephalically, opening the interbronchial angle, and displaces the esophagus dorsally. It also projects towards the left and bulges the lower third of the mid-heart border. Note the curved position of the left ventricle, which is the inferior border of the heart, and when enlarged, this border tends to reach the left chest wall. The ascending aorta projects beyond the superior vena cava, because this is the diagram of the heart of an adult. We have added color to this frontal chest röntgenogram to indicate the anatomical position of the valve, of the aortic valve. The aortic valve sits in the center of the heart, no matter what is the position of view of the heart. In other words, in the frontal, lateral obliques, and in axial images, always the aortic valve is in the center of the heart. The mitral valve, indicated as M, projects below to the left, and it is behind the plane of the aortic valve. This is a tomogram of the heart in the frontal projection, showing a heavily calcified mitral annulus outlined by arrows. The mitral annulus is visualized because calcification of the mitral valve in the frontal projection does not project in front of the thoracic spine. This is the reason why we normally don't see calcification of the aortic valve, because of the presence of the spine behind the heart, and we need oblique and lateral views to see calcification of the aortic valve. A heavily calcified mitral annulus is not an asymptomatic event in some patients. It may be associated with cardiac arrhythmias and with signs of ischemic heart disease. A simplified technique of evaluating heart size consists of drawing a vertical line that joins the spinous processes. A right horizontal line will join this line with the right border of the heart, the portion that projects further to the right, and another horizontal line joins the midline vertical line with the lateralmost portion of the left ventricle. When we add the two horizontal lines, we get the maximum transverse diameter of the heart. Then we trace the bithoracic diameter, which is a horizontal line that extends from the outermost portion of the inner thoracic cage on the right to the inner thoracic cage to the left. Some people draw this line at the level of the right diaphragmatic dome. The cardiothoracic ratio is the division of the transverse cardiac diameter with the bithoracic diameter, and normally should be less than 50%. If it is more than 50% and the person is not obese and the heart is not displaced by an elevated diaphragm, cardiomegaly should be considered. A better way of establishing heart size is to do volumetric studies. Consists of looking at frontal and lateral views of the chest. In the frontal one, we multiply the maximum longitudinal diameter, which goes from point D to point G prime. Point G prime is the junction of the left ventricle with the left dome of the diaphragm. We look at the width of the heart, which goes from point G to point D prime, and then we multiply those two numbers by the maximum AP diameter of the heart, which is traced in the lateral view of the chest. We also use a factor for men and women, and when we do all these tracings and multiply all these vectors, we get a better idea about the total volume of the heart. This is an example of true microcardia in which the heart is very small. This can be the result of developmental changes. In a very tall, slender person, the heart tends to appear very small, and it is also seen in individuals with marked hypovolemia. On an acquired basis, microcardia may reflect brown atrophy of the heart, which can be seen in patients, for example, with advanced liver cirrhosis. This is an example to your left of a hypovolemic situation where both the heart and the pulmonary vasculature appear reduced in size. The heart reflects its content, so when it's content, that means the blood volume is reduced, the heart shadow appears very small. If we were to guess what's wrong with the patient to your left, you might think it's body habitus. You might think it is due to hyperinflation of the lungs, like seen with asthma or emphysema. But this is an example of hypovolemia in a patient who had an Addisonian crisis. Profuse perspiration, massive bleeding, vomiting, diarrhea can lead to hypovolemia, and the appearance of the chest will be like we see to your left. To your right is the same patient after hydration. Note that the heart and pulmonary vasculature now appear within normal limits. That is when the blood volume was restored. The radiograph to your left simulates a widened mediastinum and an infiltrate in the right base medially. It so happens that the picture to your left was taken in expiration, and the widened mediastinum is due to a prominent thymic shadow. The classic sail shadow of a normal thymus is illustrated in this radiograph. The apparent infiltrate was due to crowded markings. The picture to the right is a few seconds after the patient took a deeper breath. Note now that the mediastinum is not widened and that there are no signs of parenchymal infiltrate. This is an example of pseudocardiomegaly in a patient with pectus excavatum deformity. Note that the left heart border is closer to the chest wall, but we do not see the right heart border as in a normal situation. Note that the patient is not rotated. In pectus excavatum, the AP diameter of the heart is decreased, so the heart develops primarily transversely. And in a frontal view of the chest, the cardiothoracic ratio may be abnormal, and the chest may suggest cardiomegaly. This is a lateral view of the chest of the same patient with pectus excavatum deformity. Note the overlapping thoracic deformity to the heart shadow and the marked reduction in the AP diameter of the heart. Some of these patients have a soft ejection systolic murmur, which may be the result of turbulence in the outflow tract of the right ventricle. Occasionally also we may see associated prolapse of the mitral valve, which may account for the heart murmur. This is the heart of an athlete. Long-distance runners, swimmers may have an enlarged heart and prominent pulmonary vasculature. And this may present differential diagnosis such as a left-to-right shunt, hypertensive cardiovascular disease. So whenever we see a slightly prominent left ventricle and prominence of the central pulmonary vasculature, we must ask what kind of physical activity the person may be engaged with. So we should be able then to identify the supernormal heart, which is the one of an athlete. The athletic heart usually presents in asymptomatic individuals. A murmur may or may not be present, and when present is usually a soft ejection systolic murmur. The chest rentgenogram may show a normal or slightly enlarged heart, a normal left ventricular contour or slightly prominent left ventricle, and the pulmonary vasculature may be a normal or slightly prominent bilaterally. The left ventricular dynamics are usually increased, and this is usually related to a slow heart rate. The electrocardiogram may reveal the left ventricular hypertrophy. The echocardiogram may reveal an end-diastolic left ventricular diameter that is increased, a thickened posterior wall of the left ventricle, and an increased ejection fraction. Scintigraphically, we may see on static images enlargement of the left ventricle, or the left ventricle may appear normal. Dynamic scintigraphy may reveal increased stroke volume, increased ejection fraction, maximum systolic ejection velocity increased, early diastolic filling rapid, and a slow heart rate with long diastolic plateaus. The heart of an adult may show some prominence of the left ventricular contour and of the thoracic aorta. AA is the ascending aorta that generally projects beyond the right wall of the superior vena cava, and AK represents the aortic knob. Conditions with normal or minimally enlarged hearts in compensated states include lesions producing pressure hypertrophy. In pressure hypertrophy, a chamber is fighting against a peripheral resistance. For example, aortic stenosis causing pressure hypertrophy of the left ventricle, or mitral stenosis in which the left atrium becomes hypertrophied as a result of a stenosed mitral valve. Conditions of pressure hypertrophy include the systemic hypertension, mitral stenosis, aortic stenosis, supravalvular aortic stenosis, and hypertrophic cardiomyopathy. Acute myocardial infarction, restricted cardiomyopathy, and constricted pericarditis generally show a normal or minimally enlarged heart. This is the heart of a hypertensive patient. Note rounding and enlargement of the free wall of the left ventricle. Also, there is a minimal prominence of the thoracic aorta. In this patient, the left ventricle is enlarged as a result of pressure hypertrophy. In this patient with a pressure hypertrophy of the left ventricle, the aortic knob was inconspicuous. Note that there is a notching of the inferior wall of the ribs. Arterial notching, venous notching, neurogenic causes, and some osseous causes can lead to notching of the lower border of the ribs. And this is indicated by the arrows in the right side of the chest. This patient had coarctation of the thoracic aorta. In this patient, note that there is a marked prominence of the left ventricle. Point G certainly is cephalad to point D. The markers indicate some enlargement of the descending aorta. This is a classic example of aortic insufficiency where there is a volume hypertrophy of the left ventricle. This is a gated chest rentgenogram, which means that it is a double exposure where the valleys represent the exposure made in left ventricular systole, and the peaks represent the position of the left ventricle in diastole. Note that there is increased excursions of the left ventricle, and also note increased excursion at the level of the arch of the aorta. This is very characteristic of a patient with a wide pulse pressure, and the basis of it is aortic insufficiency. This is another example of a volume hypertrophy of the left ventricle. Note a double density along the right heart border indicated by the right three arrows. This is an example of an enlarged left atrium as well. Along the middle third of the left heart border, we note the convexity. The lower portion represents the left atrial appendage. Note that the pulmonary vasculature is within normal limits, and also the thoracic aorta is normal in size. Whenever there is enlargement of the left ventricle, enlargement of the left atrium, and preserved pulmonary vasculature, the differential diagnosis must include, on top of the list, mitral regurgitation. So again, this is a volume hypertrophy of the left ventricle due to mitral regurgitation. There are a number of situations where there is a marked enlargement of some of the cardiac chambers. When that occurs, we must suspect volume hypertrophy in the differential diagnosis. They include mitral insufficiency, aortic insufficiency, and tricuspid insufficiency. In volume hypertrophy, the chamber leads with an increase in the amount of blood that circulates within that chamber. Congestive heart failure or simply heart failure and pericardial effusion can also lead to moderate or marked cardiomegaly. Occasionally, hearts that appear moderately enlarged and several chambers are prominent are difficult to classify. This is an example of hypertrophic cardiomyopathy. Note, however, that there is a prominence of the right ventricle, which suggests pathology at the level of the tricuspid valve or displacement of the right atrial cavity by an enlarged right ventricle. The pulmonary vasculature appears within normal limits. There is also straightening of the middle third of the left heart border. It is not possible to suspect this entity on the basis of the appearance of the heart. Cardiomyopathies may account for cardiomegaly. They're classified into hypertrophic, congestive, obliterative, and restrictive. The hypertrophic is subclassified into obstructive and non-obstructive. The most common obstructive form of cardiomyopathy is the one that causes subaortic stenosis, that is narrowing of the outflow tract of the left ventricle proximal to the aortic valve. Congestive cardiomyopathies are by far the most common, and they start with ischemic. Myocardial ischemia may produce a cardiomyopathy, usually characterized by fibrosis. Alcoholics, individuals who have been pregnant and in the puerperium can have also a congestive cardiomyopathy. Systemic hypertension, infections, infiltrating diseases of the heart, endocardial fibroelastosis, and granulomatous disorders can lead to congestive cardiomyopathy. Obliterative has been described in endomyocardial fibrosis of tropical zones, particularly in the region of Uganda, and then the Leffler's eosinophilic cardiomyopathy of temperate zones. Finally, amyloidosis can lead to a restrictive form of cardiomyopathy. In a cardiac series, we may complement with the two oblique views, the frontal and the left lateral examination of the heart. Oblique views are routinely employed at the time of cardiac catheterization. We will see with diagrams and angiocardiograms the objectives of obtaining oblique views of the heart. In the left anterior oblique, the left anterior aspect of the chest is against the film. The arms must be perpendicular to the floor, and the patient is rotated 45 degrees. This is the appearance of the heart in the left anterior oblique projection. Note that the heart appears small, and this occurs when we rotate the patient 45 degrees. If we extend the anterior wall of the trachea with an imaginary line that reaches the diaphragm, the ventral and dorsal aspects of the heart to this line are about the same. When the heart grows at the expense of the right heart chambers, then the ventral part would appear larger than the area of the dorsal part, and conversely, when there is a left heart chamber enlargement, the area of the heart dorsal to this plane increases. This is a color diagram of the heart depicting the left atrium, which appears dorsally located close to the esophagus, and ventral to it we see the right atrium. Note that we see in profile the plane of the interatrial septum. In the left anterior oblique view at 45 degrees, the septa appear in profile, and this is the preferred position for studying pathology of the interatrial and interventricular septum. Note that the arch of the aorta appears uncoiled, so it's also the ideal position of the patient to study the ascending, transverse, and descending portions of the thoracic aorta. This is the left anterior oblique rotation of a heart. This is a cast corrosion preparation. In blue are the branches of the left coronary artery. In red, the branches of the right coronary artery. Note that to the left of the LAD is the right ventricle, and to the right of the LAD is the left ventricle. The probe is in the pulmonary trunk. To the left of the LAD are the right auricular appendage and the right ventricle. And in between the right coronary artery that courses in the right atrioventricular groove. To the left of the LAD, we see the free wall of the left ventricle, and above it we see the left auricular appendage that covers the circumflex branch of the left coronary artery. This is an angiocardiogram with the patient in the left anterior oblique projection or right posterior oblique, which is the same thing. The patient was slightly rotated more than 45 degrees. We note the opacification of the superior vena cava, which is indicated as number 1, and note that it empties in the right atrium, that is indicated as number 2. Subsequent to the visualization of the right atrium, we see the right ventricle and the pulmonary trunk. The latter appears as number 5, and the right ventricle as number 4. Number 6 is the right branch of the pulmonary artery. Note that in this projection, there is no way of separating the right atrium from the right ventricle. This is the left anterior oblique view of the heart. A few seconds after the previous figure, note that there is more opacification of the right heart chambers, which occupy the ventral aspect of the heart. Again, we see in 4 the right ventricle, in 5 the pulmonary trunk, in 6 the right branch of the pulmonary artery, and in 7 we note the left pulmonary artery, which is a continuation of the course of the pulmonary trunk and branches behind the left main bronchus. In the film to the right, we see further opacification of the right heart chambers and more contrast in the lung. This is a diagram of the dextroangiocardiogram with the patient turned in the left anterior oblique projection, which is also the right posterior oblique projection. It's the same thing. Note the overlapping right ventricle with the right atrium. Note also the pulmonary trunk and the right and left branches of the pulmonary artery. This is a diagram in the left anterior oblique of the right ventricle, which is noted in the center of the heart and the right and left branches of the pulmonary artery. This is the levoangiocardiogram, which means the opacification of the left heart chambers with the person turned in the left anterior oblique projection. And note in 9 is the left atrium, which is the most dorsal chamber of the heart. In 10 is the left ventricle. We observe that there is no way of separating the left atrium from the left ventricle. The sinus of Valsalva just above the aortic valve is indicated by the curved arrow. The position of the aortic valve is always in the center of the heart. Note in 10 the ascending aorta and then the branches of the aorta. The dorsal arrow represents a site of narrowing of the proximal descending aorta. The patient had a coarctation of the thoracic aorta, and this explains the slight prominence of the ascending aorta in this child. This is a diagram of the levoangiocardiogram where we note the opacification of the dorsal chambers of the heart, the left atrium, and the left ventricle. Note the central position of the aortic valve, the ascending aorta, the arch, and the descending aorta. This is a diagram showing the position of the left ventricle, the ascending, transverse, and descending portions of the thoracic aorta. This is a composite diagram showing the left and right heart chambers. The dorsal heart chambers are the left atrium in yellow and the left ventricle in red. The ventral heart chambers are the right atrium in green and the right ventricle in blue. In the left anterior oblique, we can separate the left from the right heart chambers. It's the ideal view to study the interatrial and interventricular septa. We note also the uncoiling of the arch of the aorta, where the ascending, transverse, and descending aorta are distinctly seen. In this radiograph of the heart in the left anterior oblique, we have traced 9 squares. The home of the aortic valve is in the central square indicated by the circle. Whenever we see calcification in the center of the heart, it represents a calcified aortic valve. If the mitral valve is calcified, it projects behind, below, and to the left of the aortic valve at the junction of the dorsal lower 4 squares. The movement of the aortic valve is vertical, and the movement of the mitral valve is obliquely directed. This is a left anterior oblique view of a patient with mitral stenosis. Note that the left atrium is prominent, the left ventricle is small, and there is a prominence of the right atrium RA and of the right ventricle. If we extend a line from the anterior wall of the trachea perpendicular to the diaphragm, we note that the area of the heart ventral to this plane is greater than the area of the heart dorsal to this plane. This is indicative of prominence of the right heart chambers. We do not see it in this case, but in a penetrated view, we would see that there is also prominence of the upper lobe pulmonary vasculature. The left atrium is enlarged because of stenosis of the mitral valve. The right atrium and right ventricle are enlarged because of pulmonary hypertension leads to right ventricular enlargement, and tricuspid regurgitation can lead to right atrial enlargement. In this left anterior oblique view, we note that the area of the heart dorsal to the mid-plane is larger than ventral to this plane. This is because the left atrium and left ventricle are enlarged. The right atrium projects in front of this imaginary plane. This is the heart of a patient with mitral insufficiency, in which there is left atriomegaly. The left atrium is larger in insufficiency than in mitral stenosis. The next view of a cardiac series is a right anterior oblique view where the patient is rotated 60 degrees and the arms again are perpendicular to the floor. The oblique views of the heart are used for echocardiography and for angiocardiographic examination. In a cardiac series, we often give a barium when the patient is in the right anterior oblique, and the reason is that we would like to establish the anatomic relationship of the esophagus with the heart. Note that the esophagus descends parallel to the thoracic spine. If we rotate less than 60 degrees, then the heart and the esophagus overlap the spine. So that is the reason that the RAO is taken at 60 degrees and the LAO at 45 degrees. This is a cast corrosion preparation where the heart has been rotated to about 60 degrees. Note the atrioventricular groove with the right coronary artery. Above it is the right atrium, and below it is the right ventricle, which continues with the pulmonary trunk. The probe is in the ascending aorta. This is a color diagram showing the superior vena cava SVC and the right atrium and the terminal portion of the inferior vena cava. In this diagram, we see the right ventricle, which continues with the proximal part of the pulmonary trunk, and you can see that the arch above the pulmonary trunk is the ascending aorta. This is the dextroangiocardiograph. Note the superior vena cava labeled as 1. The arrow indicates some reflux into the left innominate vein. We also note that the superior vena cava terminates in the right atrium, indicated as a number 2. The curved arrow indicates the position of the tricuspid valve. In front of the tricuspid valve, we see the right ventricle as number 4. The angiocardiograph to the right is a few seconds later, where we see better opacification of the right ventricle and the opacification of the pulmonary trunk, labeled as number 5. The dextroangiocardiograph to your left shows the opacification of the outflow tract of the right ventricle, indicated as number 4, the pulmonary trunk number 5, and the right pulmonary artery as number 6. The dextroangiocardiograph is followed 3 seconds later by the levoangiocardiograph, which is the picture to your right, and then it shows the entrance of the pulmonary veins, indicated as number 8, into the left atrium, indicated as number 9. Note faint opacification of the left ventricle. This is the diagram of the dextroangiocardiograph, where one can see the superior vena cava terminating in the right atrium, which continues with the right ventricle, and the right ventricle with the pulmonary trunk and its branches. Note that for the first time we see in profile the plane of the tricuspid valve. This is a diagram showing the anatomic relationship between the posterior wall of the left atrium and the esophagus. Note the anatomic proximity between these two structures. This is a diagram showing the left ventricle, which continues with the ascending aorta. Between the left ventricle and the arch of the aorta is the pulmonary trunk. This is a levoangiocardiogram in a patient with coarctation of the aorta. Note the pulmonary veins, number 8, terminating in the left atrium, number 9. Between the left atrium, number 9, and the left ventricle, number 10, we see in profile the plane of the mitral valve indicated by the low curved arrow. Note that between the left ventricle and the ascending aorta, labeled number 11, there is another curved arrow anteriorly, which indicates a horseshoe-shaped aortic valve because this patient had aortic stenosis, a common anomaly associated with coarctation of the aorta. The ascending aorta, number 11, is prominent because of the area of coarctation. On the right, we see a few seconds later the levoangiocardiogram where there is a better definition of the site of the coarctation of the aorta. Note again the bicuspid aortic valve, the prominent ascending aorta, number 11. This is a diagram of the levoangiocardiogram where we note the left atrium dorsally located and the left ventricle ventrally located. Note the position of the aortic valve and of the ascending and descending portions of the thoracic aorta. This is a composite diagram in the right anterior oblique where we see the atria, which are the left atrium in yellow and the right atrium in green, dorsally located. The right ventricle in blue and the outline of the left ventricle are ventrally located chambers. This is the view that separates the atria from the ventricles. The anterior heart border is formed by the right ventricle, the pulmonary trunk, and above it the ascending aorta. In this right anterior oblique view with barium in the esophagus, we have sketched the anatomical positions of the aortic and mitral valve. Note that the aortic valve always sits in the center of the heart, and the mitral valve is dorsal to the left and inferior to the projection of the aortic valve. Note that the atria are dorsally located and the ventricles are ventrally located, and that the anterior heart border in this projection is formed by the right ventricle, pulmonary trunk, and proximal ascending aorta. In this right anterior oblique projection with barium in the esophagus, we note the focal displacement of the esophagus due to left atrial enlargement. A dorsally displaced left atrium or an intrinsically enlarged left atrium or a combination of both will displace the esophagus. The left atrium is largest in mitral insufficiency than in mitral stenosis. Therefore, if there is a focal displacement of the esophagus, this would indicate the minimal left atriomegaly and would be more related to mitral stenosis and mitral insufficiency. On the other hand, if we seek a continuous large indentation of the ventral esophagus, this would indicate the displacement of the esophagus by a moderately enlarged left atrium, which is what we see in mitral insufficiency. The left lateral view of the chest is the second most popular view for the examination of the heart. Note that we take a left lateral and not a right lateral because the heart is closer to the left chest wall, and we accomplish a less magnification when the left side of the patient is against the cassette. Note that the arms are perpendicular to the floor. This is a specimen turn in the lateral position. Note in blue the branches of the left coronary artery. Note that the ventral to the anterior descending branch of the left coronary artery is the right ventricle. And note that the left circumflex courses in the atrioventricular groove with the left auricular appendage and the left atrium above and the left ventricle below. This is the lateral view of the heart seen from the right side. Note that the only ventricle that we see is the right ventricle, which forms the anterior border of the heart. Note the right coronary artery coursing in the right atrioventricular groove with the right atrium above it and the right ventricle below it. The probe is in the pulmonary trunk. This is a left lateral view of the chest showing the heart in relationship with the esophagus. This is a left lateral chest rentgenogram with contrast in the esophagus. Note the centrally located aortic valve. The dorsal heart chambers are the left atrium superiorly and the left ventricle inferiorly. Note that the esophagus parallels the thoracic spine. Whenever there is a left atriomegaly or there is a dorsal displacement of the left atrium, we may see localized displacement of the thoracic esophagus. The chamber of the heart that contacts the sternum is the right ventricle. In this left lateral view of the chest, we note outlined by arrows a heavily calcified aortic valve. The aortic valve sits anatomically in the center of the heart, no matter what is the way that we look at the heart, be that in conventional rentgenograms or axial images of the heart. When the aortic valve appears heavily calcified, we can expect that there is a high gradient secondary to associated aortic stenosis. The cause of the calcification is calcific aortic stenosis. The findings in this left lateral view of the chest are pathognomonic of mitral stenosis with pulmonary hypertension. Note the focally displaced esophagus secondary to an enlarged left atrium, which is also dorsally displaced by the ventrally enlarged right ventricle. Note that below the left atrium, the left ventricle does not appear enlarged. Note an increase in the surface contact of the heart with the sternum at the site where the right ventricle is located. And this is the result of pulmonary arterial hypertension. Note also that the vessels that we see through the heart are more prominent in the upper aspect of the lungs. This is what has been described as the hemihylous sign due to flow reversal, where the vessels in the upper zones are more prominent than those in the lower zones. In summary, this patient had an enlarged AP diameter of the heart due to prominence of the left atrium and right ventricle. The prominence of the left atrium is the result of mitral stenosis. The prominence of the right ventricle is the result of pulmonary hypertension. This is an anatomical section of the upper aspect of the thorax. You can see to your left the right lung and to your right the left lung. Note the trachea, and on both sides of the trachea we see thick rings that represent the carotid and subclavian arteries. This is the CT that corresponds to the previous anatomical section, where we note again in white the calcific densities of the bones, and note that the origin of the carotids and subclavian arteries are heavily calcified. The black central structure represents the trachea, and on both sides of the midline we see the left lung and the right lung. This is an axial view at the level of the shoulders. To your left is the right lung, to your right is the left lung. And note that we see the trachea in front of the spine, and to the left of the trachea we see a cross-section of the takeoff of the brachiocephalic vessels. To the left of the trachea we note the origin of the brachiocephalic arteries, the innominate, the left carotid, the left subclavian, and the distal part of the aortic arch. We see in yellow the outline of these vessels because they were heavily calcified, as it will be shown in the CT of this same anatomical section. An incidental finding is a cavity in the right lung. This is the horizontal section that corresponds to the anatomical section previously described. Note the heavily calcified takeoff of the brachiocephalic arteries. The black lungs show on the right side a lesion that was seen in the anatomical specimen. In white we see calcific densities from bony structures and arteries, and the brownish color represent the muscles. This is an anatomical section at the mid portion of the heart. The central structure represents the ascending aorta. Ventral, and to your left is the right atrium. Behind the aorta is the left atrium. In front and to the right of the aorta, we see the outflow tract of the right ventricle, and the muscular structure to the left of the aorta represents the left ventricle. Note the right lung with the bronchi that appear calcified, and note also that the descending aorta appears heavily calcified. This is a CT section that corresponds to the previous anatomical section. And note the centrally placed aorta with calcium in its walls. Again, we see a heavily calcified descending aorta. This is a cross-section with MR of the heart where we can see the similarity between the appearance of the cardiac chambers and major vessels with the anatomical specimen described previously. Note again the central position of the ascending aorta close to the aortic valve. This is a cross-section at the level of the aortic valve using computer tomography. Note the leaflets of the normal aortic valve, which again always sits in the center of the heart. Note the aortic valve in systole and in diastole. The systolic image, which is the one that you see to your left, shows that the valve leaflets do not reach the inner wall of the aorta. This is the region of the sinus of Valsalva. That means that we never see the total opening of the aortic valve. On the right side, you note the apposition of the valve leaflets during diastole. And now we can distinctly see the space between the valve leaflets and the wall of the aorta, which is the home of the sinus of Valsalva. This is the lowest section that we made of the heart, where we can see the trabeculated right ventricle in front, the right atrium to your left, the thick-walled left ventricle with a very thick interventricular septum. Note the very thin interatrial septum, and behind it you can see the left atrium. We again note the very heavily calcified descending aorta. If we turn the anatomical section in such a way that the left ventricle is to your left and the right ventricle to your right, note the similarity between the anatomy of the heart and the anatomy of the heart seen by echocardiography. In echocardiography, when we place a transducer in the apical position, you can see the interventricular septum separating the ventricles, and the left atrium dorsally and the right atrium as well dorsally, but slightly in front of the left atrium. Note the entrance of the pulmonary veins in the left atrium. This is an ultra-fast CT section where we can see a heavily calcified aortic valve. Period note calcification in the right coronary artery as well as in the left. This happens to be my heart before I had aortic valve replacement with a cadaver homograft. This was an incidental finding when I volunteered to be studied with the ultra-fast computed tomography in 1989. This is an ultra-fast CT section of the heart where we note a heavily calcified origin of the left coronary artery. Also, we note a speckle of calcium in the right coronary artery. This is the best method to diagnose and quantify atherosclerotic disease involving the coronary arteries. In the normal individual, we see the right lung, which has 3 lobes and has a short right main bronchus, and the left lung, which has 2 lobes and a long left main stem bronchus. Note that the right atrium is anatomically located to the right of the left atrium. The liver is in the right upper quadrant, and the stomach and spleen in the left upper quadrant. When we have a situation of situs inversus universalis, which means that there is a mirror image of the thoracic and abdominal organs, we note that the trilobed lung represents, in this case, the left lung, and the right lung is a bilobed lung with a long right main bronchus. In such a situation, the liver is under the left hemidiaphragm, and the spleen and bubble of the stomach appear under the right hemidiaphragm. When this occurs, the right atrium is to the left of the left atrium. When patients have what is called right isomerism, the two lungs are trilobed, and the right atria appear symmetrically located on both sides of the midline. We also note that the liver is a midline structure like the stomach. When there is a levoisomerism, the two lungs are bilobed, and the left atrium is symmetrically located with the liver and stomach appearing also in the midline. In this situation, we can see splenunculi, which are multiple pieces of spleen scattered in the abdomen. Generally, the right atrium corresponds to the position of the liver, and the left atrium to the position of the stomach. The ascending aorta indicates the position of the right ventricle, and the pulmonary trunk the position of the left ventricle. There are several bronchial isomerism syndromes. The first one is the Ivemark asplenia syndrome, where there is a right isomerism, meaning that the two lungs are trilobed. In the Ivemark asplenia syndrome, there are congenital heart diseases that are either transposition with either pulmonic stenosis or pulmonary atresia, common ventricle, or a large atrial septal defect. So when one looks at a chest rentgenogram and observes the presence of three lobes, one must consider this possibility. In the second isomerism is called the M anisosplenia. In such a situation, the two lungs are trilobed. There is one or more larger or one or more smaller spleens. The visceral situs is relatively normal, and there may be congenital heart disease. In the third possibility is the polysplenia syndrome, where we see two lobe bifurcation of the bronchus, and that is called levoisomerism or left isomerism. 4 to 14 uniform spleens called splenunculi is observed, and also congenital heart disease in the forms of atrial or ventricular septal defects. The last of the isomerism syndrome is the F anisosplenia, where the two lungs are bilobed. There is relatively normal visceral situs, and the congenital heart disease is characterized by a predominance of the double outlet right ventricle. In summary, when we are trying to determine the anatomic location of the atria, we should look at the position of the liver. When the liver is under the right hemidiaphragm, the right atrium is to the right of the left atrium. Conversely, when the liver is under the left dome of the diaphragm, the right atrium is to the left of the left atrium. The positions of the ventricles is determined by the position of the ascending aorta and pulmonary trunk. The right ventricle is to be suspected to the right of the left ventricle when the ascending aorta is to the right of the pulmonary trunk. And the left ventricle corresponds to the position of the pulmonary trunk, which is in front and to the left of the aorta. So the aorta and pulmonary arteries determine the position of the ventricles, and the liver determines the position of the right atrium, as well as the stomach, the position of the left atrium. When the liver is in the midline or any other of the abdominal structures are in the midline, then it is not possible to predict the anatomic position or the type of atria that we're dealing with. This is the asplenia syndrome, which has an incidence as an isolated anomaly of 24%. Associated malformations are seen in 76% of patients, and cardiac are 26%, the most common being a common AV canal, transposition of the great arteries, pulmonic stenosis or pulmonary atresia, persistent truncus arteriosus, vascular anomalies and decreased pulmonary vascularity. Situs anomalies have been described in 37%, and they usually consist of dextroisomerism. And non-cardiac, non-situs anomalies is seen in about 5% of patients. The last syndrome we're going to discuss is the polysplenia syndrome. It is a type of situs ambiguous characterized by levoisomerism and abdominal heterotaxia. First, the syndrome is characterized by multilobate spleens or by several splenic nodules that are scattered in the abdomen, particularly along the greater curvature of the stomach. The second abnormality is levoisomerism, which is bilateral left-sidedness. And we look at the plain X-ray and find that the two main bronchi are long and give off only two lobes on each side. The third are the cardiovascular abnormalities. Although the heart may be normal, we may have a number of anomalies such as absence of the hepatic segment of the inferior vena cava with azygos or hemiazygos continuation. We may also see transposition of the great arteries, and dextrocardia may be present. Another anomaly is a preduodenal portal vein. The fourth group of anomalies are gastrointestinal and consist of a liver in the midline or on the left side. The pancreas may be short. They may be intestinal malrotation. Finally, a number of genitourinary abnormalities may be encountered, such as a double ureters, renal agenesis, and hypoplastic kidneys.